Dr. Shiv Kumar, Phacotraining Guidance. Yeah. Synopsis.
Good afternoon, everyone. Good afternoon, the judges. So, as we are seeing, Phacotraining has become a fundamental requirement for most anti-segment surgeons. The task has been taken lightly by some and very seriously by many. So, to get into the details, the options earlier we had were as simple as some of them was directly asked to do a surgery directly on a patient. Some have already tried on animal eyes. Others have tried on tomatoes and cell phones, cell phone tape. So the advanced options are, this is something called as an IC virtual reality enabled device. Other things like help me see augmented reality where they train perfectly for a SICS and a 3D visualization system. The more these three are the expensive options. The wet labs, our own wet labs, and a wet lab aided by a Kitaro unit from Japan is equally useful. As we'll see, the Help Me See training method has been quite good and is available easily. It has used very augmented reality technology where the realistic tissue feel and behavior is there. In addition, there is also a 3D visualization system which many of you must be aware. It provides enhanced precision and depth perception. It also, the surgical microscope is optimized for utilization. This is a very expensive option as of now. So, medical teaching must at some point use live patients to hone the skills of health professionals. So, the traditional methods involve this method directly. Obligation to provide optimal treatment and to ensure patient safety is very important. The old saying, see one, do one, teach one, still holds good, but it's sometimes risky. So, the challenges are, patients are to be protected whenever possible and they are not commodities to be used as conveniences of training. So, the best standard for patient care has to be established and maintained, and first, do no harm to patients is important. Using patients as learning instruments is only justified when all approaches to minimize risks have been taken. Simulation allows trainees' first encounters with real patients to be at higher technical and clinical proficiencies, and this has been proved scientifically. The challenges of standard patient care and standard for education. Once trainees come out of standard education, they should be very confident to handle patients directly. So standard for evaluation, nowadays most evaluation of clinical skills is very biased and subjective by professionals because how much level you attained is not clearly established. With the evaluation methods of simulators, the standards were very attitudinal and psychomotor also. They can be exactly evaluated. Error management also is superior. Even with supervision, it is inevitable that trainees cause preventable injuries. In clinical settings, errors must be stopped promptly. In simulation, errors may be allowed to continue and the trainee is allowed to experience how to deal with a difficulty. So simulators enable sufficient opportunities for practice, exposure to infrequent yet critical scenarios. Some of the trainees may have critical steps which are difficult to learn. So each student can be customized and proper training can be done. Standardization also is easy. Patient variability is expected. Feedback and instructional controls are very modifiable. So the powerful motivators to use stimulators are the lower cost and better access to symptoms and reduced training time and reduced errors. So conclusions, before joining a formal course, most students must use some methods of training in their own offices, in their own practice, before they actually train a